Ladies and gentlemen, please join me to welcome Madam Ranjit Kaur, the President of Breast Cancer Welfare Association Malaysia, to deliver her topic on How Will I Cope If I Have a Breast Cancer? Brief introduction about Madam Ranjit Kaur. She is a breast cancer survivor since 1998. She has a basic qualification in physiotherapy and Master of Science degree in Community Disability Studies from University College London, United Kingdom in 1996. Madam Ranjit Kaur is a board member for Reach to Recovery International, a global breast cancer support and advocacy program. She is also a patient advocate for Union for International Cancer Control, UICC. She has received the 2004 Outstanding UICC Volunteer Award and the Theresa Lazer Award conferred by Reach to Recovery International in 2011. Let's welcome Madam Ranjit Kaur to the stage.
Good afternoon. And I would like to thank the organizers for inviting me to speak here. As you can see, my topic is slightly different from what was mentioned just now. I just shortened it to coping with breast cancer. And a lot of it is to do with what people experience when they go through breast cancer. Just a few quotes here of when the doctor told the patient or broke the bad news to the patient. You get these type of comments or remarks of patients saying, I felt numb, or it was surreal, nothing was going into my head. All I could think of was my children. What is going to happen to them? Am I going to die? How long more do I have? This is the human side of when bad news is broken to patients. And this is what is going on in the patient's head while he or she is in the hospital in front of the doctor when the doctor informs that the patient has cancer. There's a huge psychosocial impact. There are 4 aspects of ourselves: the physical, the social, the psychological, and the spiritual. I think earlier on Dr. Richard Lim had spoken about it. So there are different psychosocial impacts of cancer: facing depression, anxiety, fear, anger, guilt, loss of control, avoidance, optimism. Why optimism? So what I did just now was, these are the areas that brings about a lot of negative impact, but it is part and parcel of coping with a condition like cancer. But there is sometimes optimism when the doctor says, I can treat you and you can continue to live. There is the feeling of altruism, wanting to do something for society after having gone through this experience and this challenging journey. Relief, that there is hope, even sometimes relief because the diagnosis has been made. All this while the patients may have been on a runaround to find out what exactly is wrong with them. Searching for meaning. There must be something beyond this, some bigger plan for me, and that is why I have a disease like this. A sense of purpose. I want to do something. So there is the positive and the negatives that come out of the psychological impact of cancer. It's not negative all the time. This is a paper that was a study that was done, a qualitative study that was done by Prof. Aisha from UMMC together with Professor Yip and others from University Malaya Medical Center regarding reasons for late presentation. Why am I presenting this is because in Malaysia more than almost 50% of cases of breast cancer are late presentations. And the reasons that were given on this qualitative study was, one was fatalism. That coping mechanism towards fatalistic outcomes like denial and avoidance contribute to this late stage presentation. Belief in alternative therapy as an active form of treatment and a more acceptable option of treatment. We sometimes do tell doctors, you're not as good a salesman as the alternative treatment guy. The alternative guys can sell their products much faster than a doctor can actually promote their treatment. And that's because most of the time the doctors are very factual. They have to tell the truth. Whereas the alternative guys make a lot of promises. And finally, the patient will end up in the hospital. Decision making, lack of individualistic or autonomous decision making, with women playing the role of a dutiful wife and daughter. Women need sanctioning to see a doctor in some places, not everywhere. I don't know whether this comes from the women themselves or whether it really comes from the lifestyle, or even whether the men want it that way. So far, I've not come across much of that, because I realize that sometimes the autonomy is given to the women, but the women make such decisions themselves by saying that they want others to make the final decision for them. Poor breast health literacy was one other aspect. Now, the thing is, many a time people ask us, why is it that when we go out and we do so much of education on breast cancer, and yet people are presenting late? There must be a deep psychosocial factor rather than just otherwise the intellectual part. There are coping mechanisms, there are various situations. There's also the financial suffering that has been highlighted very recently in the action study that was done some years ago, where families are using a lot of their savings. More than 30% if spent on medical expenses per month would actually mean that there is financial catastrophe. And is this something that people are fearing, that they would not go to do an early presentation of their disease? There have been a lot of different types of financial bankruptcy and catastrophe or toxicity that has taken place due to late presentations as well. Now, when it comes to surgery in breast cancer, when we talk about coping with breast cancer, when the healthcare professionals say that I will do a mastectomy or a breast conserving surgery, the medical people are looking at it more from the medical point of view, whereas the patient's perspective of looking at herself as loss of body image. So these are two different parallel lines that are running along. They don't converge much. And there needs to be some kind of convergence here. And I think that in some hospitals, this has started happening with oncoplastic surgery that has been a bit more rampant now in the hospitals, which are saving the women from just losing the breast, but also gaining a new breast back. And how does breast cancer affect people? It is a major life stress. We know that there is post-traumatic stress disorder related to breast cancer. Difficult emotions to deal with, such as anxiety and depression. There is uncertainty about the future. Fear of recurrence is a huge thing, and that is why many patients end up asking, what should I not eat? What should I avoid? And these are all coming from a lot of advice that friends are giving, that they shouldn't take chicken and sugar and I don't know what else. This is very much related to fear of recurrence among the patients who end up having a very poor diet because they go into the internet, they get lots of information which is misinformation, I should say, and they start following that. And some go vegetarians overnight, and they are not strong enough sometimes to take the treatment either. Changes in social relationships. Women like to be the carers of others. They always fear being cared for. They always fear being dependent on somebody else to be cared for. And there's always that feeling that I may be just bedridden. There is very little knowledge about what life is like after breast cancer for many people who have no exposure to breast cancer. And when we tell them that life can be normal, it is surprising for them because they think that cancer means it is death and you're going to be really, really in bad physical shape. So changes in social relationships sometimes can take place even with the partner, even with friends, with colleagues. I think that the social aspect is very, very important aspect, although it is not addressed formally by any sector, except probably by the NGOs. Self-image and sexuality concerns, these are concerns regarding how a woman feels about her body. What does she feel about it when she knows that part of it is going to be mutilated? That has to be dealt with. And people need to deal with that together with somebody else who has either experience or expertise in this area. Treatment side effects. It does affect patients a great deal. Somehow, the first hurdle, which is surgery, once they get through that, only then they start thinking about the next hurdle, whether they're going to have chemotherapy. And majority of the patients in Malaysia actually need to go through chemotherapy, and they're so fearful about chemotherapy. The fear seems to be more than the actual experience, actually. It's much more devastating just imagining it for them than actually having gone through it after that. Financial stress. Is she going to be a burden to her family? Are the life savings for her children's education going to be used for her treatment? So there is clinically significant distress. Studies have shown anxiety, depression, and post-traumatic stress disorder does happen with patients after breast cancer. As I mentioned earlier, the fear of recurrence, dealing with uncertainty, confusion about lifestyle choices is a great issue with many new patients. Now, just giving you this face here, this lady passed away just a few weeks ago. She had a rare form of breast cancer. You can see her young children. She's left them behind, and her husband. So it can be devastating. So psychosocial interventions do help to improve quality of life. There are various types of interventions, starting from professional interventions of psychosocial support, to peer support, to decisional support, particularly when it comes to making decisions. Crisis intervention, when the patient feels anxiety and depression has become clinically significant. There are issues of problem solving, where to get resources from, information on referrals, psychotherapy, therapeutic rituals, even when it comes to informal social situations in their own community. Now, we know that when it comes to diseases, or even anything that is to do with suffering, most women are quite okay to talk. Women talk. Women love talking. Give them any topic and they'll talk. Yeah. Men don't talk. Okay. When they started cancer groups for men, and we got the men together and we asked them to talk, they talk about what's the latest treatment. So when we started doing training for men with cancer, when we talked about feelings and emotions, they said, we don't have such things, you know. Doctor tells us we've got the disease, we just ask them what's the latest treatment, we get it done. And if we can't find it, we go and find from some other country. So it took us about one day to eventually get the men to say, yes, we did feel depressed, we did have anxiety, we still do have some fears of recurrence. And that's the reason why they're looking for treatment anyway, right? So yes, but women tend to be more open in talking. They can sit, they can chat with each other, they can talk about anything. And let me tell you, if some of you who are doctors here, patients sitting outside your clinic have already made a lot of decisions outside as to what they're going to do next, which has got nothing to do with your treatment. Why? Because they talk to each other while they're waiting for the doctor. So the reach to recovery concept was started from women talking among themselves. So if women talk, we may need to give them the right information so that they can say the right things, right? So reach to recovery was started by this woman called Theresa Lesser in 1950s, early 1950s in New York. Theresa Lesser was diagnosed with breast cancer, and in those days, after surgery, people used to be kept in hospital for a week. Now she felt very lonely and very fearful and felt the great uncertainty of her future at that time, and there was nobody that she could ask questions. Nurses came in and out, giving her all kinds of medication and also checking her temperature and blood pressure. Doctors came to see her, but she had nobody whom she could relate to. So what she did was, when she got out of hospital and she finished with her treatment, she started going back into the same hospital to see new patients who had breast cancer. And she was thrown out of the hospitals because she had no right to go in and see a stranger. Eventually, she started this program called Reach to Recovery. It started as Reach for Recovery, but it ended up as Reach to Recovery. And it is now an international organization called Reach to Recovery International. And it was first taken up by the American Cancer Society, later by the Union Against Cancer Control, and now it is all over the world, and Reach to Recovery International is an international NGO registered in the US. So what happened was, Theresa Lesser decided that training needs to be given if we want women to go and visit patients in the hospital. So at that time, they had very strict criteria whereby a woman had to be free of cancer for at least 2 years after treatment and certified by the doctor before she was accepted for training. We give 3 days training to women who have completed treatment, are physically fit and emotionally adjusted back to life again, so that they can be trained and supervised to visit new patients in the hospital and give them support, non-medical support. And in this support, you give emotional support, practical information, social support as like buddies or friends, self-image and sexuality issues are dealt with, and they also deal with mortality issues which the patients face. So the main thing is that the woman has experience, has had breast cancer experience and treatment experience in the past. She's been trained and she's being supervised. She gets recertified every year so that she can keep up, and she also is examined to see that she is still physically fit and emotionally adjusted. So what does it do? What does this program do? It decreases mood disturbance, it decreases psychological problems, and increased positive coping skills, decreased pain, better informed patients, and realistic expectations. What happens is that a new patient lying in bed in the ward after surgery meets with this new patient who walks up to her, meets with this woman who has lived experience of breast cancer and is trained. She sees her and she says, "You look so healthy. You don't look like you have breast cancer." Now that's what a new patient is going to say to someone who's had that experience, because that new patient has never met someone who's had breast cancer experience before. And that in itself, that role modeling itself, helps the new patient a great deal. Seeing someone alive, standing in front of her after breast cancer, is for her a proof that there can be life after breast cancer. And that's when she can ask her questions that she didn't know who to ask. What is chemotherapy? How is it given? I hear a lot of bad things about it. What is radiotherapy? What's the difference between radiotherapy and chemotherapy? She doesn't know about that. So the patient, the survivor then tells her, the peer support volunteer then tells her. So this is a program run by Breast Cancer Welfare Association Malaysia. We give Reach to Recovery peer support training to breast cancer survivors all over the country. And we go to those different parts of the country to give training. And the trained breast cancer survivors then give psychosocial support and material support to patients. The doctor seeks the patient's permission first, whether the peer support volunteer can visit the patient or not. So the patient's autonomy is very important, the patient's privacy is very important, the patient's permission is very important. So the criteria, as I had mentioned, someone who's had lived experience of breast cancer, physically fit, adjusted psychologically after treatment, models a return to good health, You surely want somebody who looks healthy and confident to walk up to you if you've had breast cancer. Carefully selected and trained. We sometimes train 20 people, we only get 3 who qualify to visit the patient, because the rest of them probably are not yet ready to give support. Or they may be very emotional when seeing patients, seeing other people. They're still dealing with their own issues. Carefully selected and trained, able to articulate effective coping strategies, which we usually do when we do a lot of role plays and practicals during the training to find out exactly how this person looks at coping skills and how she has coped herself in the past, because we talk a lot about their own experience as well to see where they stand. And they're committed to continuing training, education, and supervision. The criteria is quite strict once they become volunteers and they're supervised. If they do go off the line, they do get suspended, because the fear is the patient is the most important person for us. And if we do get complaints from doctors or patients, because patients go back to doctors and say, that lady who came to visit me said this to me. So doctors do feedback to us, so we come to know what's happening. Now this is the information kit. As you can see on the left, we give them a bag. Now this bag is for putting the drainage bottle. You know, there are drainage tubes with the bottles at the end. This is for putting that in. It's a practical bag where they can put their hand through, because after breast cancer, once they are off the anesthetic effect, they're supposed to be walking to reduce the risk of DVT. So this bag is very useful because they can just sling it in their arm, go to toilet, walk around, go for coffee downstairs, and it's easier for them. Rather than, I've seen some of them carry plastic bag and walking around, you know, before we see them, they're with a plastic bag or they're just holding the bottle. We give them a stress ball. We sometimes give the stress ball to the doctors as well because they need it. We need to start giving it to the nurses as well, but they're always running around so busy. We give them a book to say, which has a lot of practical information on how to cope with breast cancer, what to do, how to manage side effects during the different treatments, and as well as those who lose their breast to mastectomy, we give them a temporary prosthesis, which is sewn by our Thimble Thumb team of women with breast cancer. They come weekly to our center to do the stitching of the fiber prosthesis. We found that the mastectomy bras can be quite expensive for some communities because they can cost up to 200 or 250 and above. So what we did was we worked with a factory, and the factory has produced low-cost mastectomy bras. We sell them 50 ringgit for the women so that they can come and buy them whenever they wish to. We also give free wigs. We have a wig bank for women to select. And we have shaving and wig styling services by a hairstylist. So you can see on the left is the shaving going on. And it is in the privacy of a private room in the saloon itself. And on the right, you can see that the woman is actually wearing a very well-styled wig that doesn't look like a wig. Surely, when it comes to sexuality and self-image, it's very important for a woman to feel good about herself. And this well-styled wig actually helps the woman to feel much better, that nobody is staring at her, looking at her in an odd way. So why do women need counseling? Why do they need support? When do people need support? It's when people are facing difficulties in personal life, relationships, and social life. So these are the three main areas that we always need support from other people, whether it is a disease, whether it is some crisis in life, we need someone to give us support. And breast cancer is one of them. Now, what are the skills, the basic skills that a peer support volunteer needs to have? Good listening skills, not good talking skills, that's bad. Good listening skills, ability to communicate care and concern and be compassionate, positive mindset, a very optimistic outlook of life, able to express empathy easily, a non-judgmental person, respecting patient and respecting confidentiality, cannot interfere with doctor-patient relationship. We find that the women from the kampong are easier to train. than the people who are IT savvy and know a little bit more. They are more dangerous, yeah, because they can get into the medical area quite easily. Whereas the women in the kampong are so much simpler, and it's easier to train them up. They know nothing about the medical part. It's easier for them to just sit down and give support to someone. And we don't allow our peer support volunteers to give medical advice because that is not their area, and they're not allowed to. They're not even allowed to mention names of doctors, names of hospitals either. Now, there is life after breast cancer is what we decided to show people. As you can see, we have a dragon boat team that goes to various countries for competitions. This is from a study that says in Canada that says that lymphedema risk can be reduced if you do activities like dragon boat paddling. Mind you, it doesn't use the arm much, it uses the upper body. It uses the muscles of the upper body and the shoulders, not so much the arm movement. The whole body has to move. And we also have a bowling team that does bowling regularly, and they also organize competitions among cancer survivors together with the public. And we have a group called Pink Melody, which is a singing group that allows for women to come and be part of a choir. And they are actually trained by a vocalist, a professional vocalist. And mind you, they used to croak before. They sing very well now. So these are what we call survivorship. It creates camaraderie. It also gives a sense of confidence for people to come out in public and feel more confident that there is life after breast cancer and they can take up leadership roles in their lives. There is also organizing of talks by experts so that women can be educated about life after breast cancer and given more information, and we allow for their carers and their family members to be part of these talks on various topics as well. Now, a bit about the association. We were founded in 1986 by two general surgeons. Both were men who felt that there was a need for women with breast cancer to form a support group and to give support to one another. And we got registered with the Registrar of Societies in 1988. We are a tax-exempt organization. And mentioned just now, we're a member of the UICC, the Reach to Recovery International, and I'm also a board member of the Advanced Breast Cancer Global Alliance. The two main areas that we do is to improve quality of life for individuals affected by breast cancer and reduce the risk of premature mortality through public education, early detection of breast cancer, and navigation of women for further investigations and timely medical treatment. I think what you are seeing today out there is the inflatable clinic. Yes, inflatable. I've got only 2 slides to go. Inflatable clinic you can see out there. This is used in the rural areas. It's also used in factories and kampongs where it's easier for us for our nurses to examine people. We also have the Murni mobile clinic, which goes around to various places where there is access. And that's the interior of the clinic where the nurses, our senior nurses, do clinical breast exam. And in conclusion, I would say that cancer has a very powerful emotional impact on patients and their families throughout the continuum of during diagnosis, treatment, and also after and beyond. Psychosocial care is an integral part of quality care. And it is not one size fits all. Matching resources and services to the needs of patients makes for effective use of resources and is likely to promote optimal adjustment of patients and their families. So coping is not just one aspect, but it is many, many aspects for the patient to be able to take control of their lives later on and get on with life again with a renewed energy and vigor. Thank you very much.
Thank you, Madam Ranjit, for sharing your experience with us. We are able to get some ideas and valuable input from your sharing. Madam Ranjit, please remain on the stage. Please welcome our Head of Subject, Madam Nik Mariani, to present a token of appreciation to Madam Ranjit Kaur. sini ke? On the way. Sampai sekarang. Thank you to Madam Ranjit Kaur and Madam Nick.